2003. Most of the progress, or much of the progress in terms of policy and implementation, I think can really be laid on his shoulders, and especially in sub-Saharan Africa. He's really been and actually globally, he's really been a driver in this area. So it's really great to have him with us, and he's going to give us his views on ART and tuberculosis and TasP.
Thank you, Ruben, for that introduction. So what I'm going to do with my presentation is to give you the magnitude of TB in terms of mortality and morbidity for people living with HIV, and then give you the latest in terms of preventing TB in people living with HIV using ART and IPT, and also the need for diagnosis, and I will discuss programmatic and research issues and then conclude. This is a slide that actually summarizes very selective autopsy studies that were done between 1991 until 2009, if you wish, just in the pre-ART era. And as you can see from this slide, regardless whether it's in sub-Saharan Africa, Asia, or Northern America, autopsy studies done among people living with HIV have actually showed a high rate of presence of TB in cadavers, ranging between 33 to almost 80%. What about now? This is a slide actually summarizes 3 autopsy studies that were reported in the recent CROI 2013 that was held last month. And in the first study, which was done in South Africa, where they actually collected people dying at their home in a HIV setting, and they did autopsy in all people living in all people dying in the community, and they found 34% of the cadavers having TB. And this study that was done in Kenya, among those people receiving ART, with a median ART for 10 months, actually showed also 52% of them were having TB in their cadavers. And the third study that was reported from South Africa, among those people living with HIV who died within the first 3 months of ART initiation, also showed 21% of them were having TB in their cadaver. So this actually is really, for the first time, actually, all this spectrum of people living with HIV being, presented in autopsy studies, and really shows how we are really lagging behind, despite the progress, encouraging progress that was reported by Sumia, really in addressing TB among people living with HIV. So this is also the other study that was reported from South Africa, from Steve Lown's group, which was published last month in PLOS ONE, which actually showed the cohort that were followed on ART for 8 years, and they analyzed those who survived. I think there were like 1,500 cases, and out of those 800 were surviving by January 2011. And what they found was, where at the time of ART initiation, 45% were really having a past history, treated TB history, and at the time of ART initiation, 26%, or 1 out of 4, were actually presenting with TB, and they were taking TB treatment. And almost a third, 29%, developed TB while they are still on ART. So again, this shows what the magnitude of TB in people living with HIV, despite our efforts really to scale up ART in a very dramatic way in the last decade. So this is a slide that shows how IPT works. IPT prevents TB, particularly in skin test positive people living with HIV. And there are marginal but not significant reduction effect also on mortality, although debated because of selection of cases and all the like. in terms of its effect on mortality, but there is clear evidence that IPT prevents TB in people living with HIV, and this is a result of a Cochrane review. And we also know a randomized controlled trial that was done in South Africa and reported at IAS in July showed when IPT and ART are used in people living with HIV, regardless of the TST result, we can get almost 40% protection from TB. This is also the systematic review that we did for the studies that really looked randomized control trials for CD4 count. And as you can see, in the three categories of CD4 count, between less than 200, between 200 and 350, and 300 more than 350, we saw that providing ART earlier has a higher protection of TB. And as you can see, in less than 200, there is 84% protection, between 200 and 350, 66%, and when people are getting it more than, when their CD4 count is still more than 350, and actually the upper range for this group was 550, the protection is almost 60%. So this is a very clear evidence that ART, especially earlier ART, has a prevention effect on TB. The other finding is also the synergistic effect of IPT and ART, and as you can see from this slide, there are studies that actually showed, two observational, the first two from Brazil and South Africa, and one randomized control trial, which actually showed if we use ART and IPT together, we can lead into almost elimination of TB among people living with HIV. So what is the problem? One is clearly the delay in diagnosis of TB among people living with HIV, and this is just what I quickly reviewed in papers published since 2012, and one from Brazil that actually looked into referral HIV/AIDS centers to look the delay in diagnosis, and the diagnostic delay for diagnosing TB in people living with HIV actually ranged up to 552 days with a median of 41 in these HIV centers. And this one from Malawi, which was done in two referral hospital centers and ART centers in 2010-2011, actually showed if the TB is diagnosed bacteriologically, mainly if it is a smear positive by microscopy, the delay was 27 days. And when it was a smear negative and when the diagnosis was done clinically, which is the commonest form of TB among people living with HIV, the delay was up to 87 days with a median of 47 days. So what can we do? And GeneXpert is the new molecular diagnosis that identifies the DNA of the mycobacteria in a very simple 6-7 steps procedure where you can really put the sputum after processing in a cartridge, and you find the result, not only the presence of mycobacteria, but also the presence of rifampicin resistance. And GeneXpert also provides potential platform for determining viral load as well as diagnosis of sexually transmitted infections. And when we look into the evidence around GeneXpert for sensitivity of diagnosing TB, this is a recent Cochrane review that was published a month ago. You can see that if the smear positive, for culture positive, the sensitivity is 98%, for smear negative, 68, and for people living with HIV, regardless of the smear, it was 80, and for HIV negatives, 89. And this is the only test that is available today that actually show no difference based on HIV status. All the other TB investigation, microscopy or culture, all actually shows their performance differs based on the HIV status, and GeneXpert is the one that almost shows equivalent sensitivity. And this is another study that was reported from Cape Town, where they actually used GeneXpert as a screening tool for people living with HIV regardless of TB, and you can see the comparison between microscopy and expert. And when they used for all samples, the sensitivity of microscopy was 28, which was increased to 73 if they used GeneXpert. And for one sample, it was 52. When it was done on two samples, the sensitivity increases to 72%, which means overall there was a 45% increase in detecting TB in people living with HIV when GeneXpert was used regardless of symptoms as compared to microscopy. And this is a WHO recommendation around treatment of ART for TB patients. And it's been recommended since 2010 that all TB patients should get ART regardless of CD4 count. And the ART should be as soon as possible, within 8 weeks, and following the compelling result of the 3 clinical trials that were reported in 2011, I think, that we also recommend, especially for those with profound immunosuppression, particularly those with less than 50 CD4 count, should get their ART and TB treatment together within the first 2 weeks. And also, as it was presented earlier by Meg, the new ART guidelines are also proposing initiating ART at a higher CD4 count, which, as I showed you earlier, will have also a useful TB preventive impact. But when we really look into the progress, and this is just to summarize how we are progressing in providing HIV testing for TB patients, and this really shows the progress in blue dotted line for Africa over the last 5 years. And Africa, by the end of 2011, almost 70% of TB patients notified, this is not estimates, these are notified TB patients coming to the facilities, were reported to be HIV tested, which was much more higher than the global 40% figure. And as you see, in Africa, there is much HIV testing going on. But when we really look the provision of ART for TB patients, you can see Africa actually lags behind even the global average. This is potentially could be also because other regions are testing less, and they are also able to put people living with HIV in on ART on limited scale, but still it shows the disparity between expanded HIV testing and limited availability of ART. And the other point is also the inequality or the inequity of ART access for all people living with HIV and for those people living with HIV who newly developed ART. This is really from eligibles, estimated, and actual reported notified TB cases. So by 2011, globally it is 54% of people living with HIV eligible for ART received it, but that figure was less than 50, 48% for TB patients. There could be several reasons for this, the problem with early diagnosis, co-treatment, IRIS, all the other issues. But so the bottom line is there is inequity that has to be addressed in terms of access for ART. This is just to show you the ART coverage, how varies from countries, particularly in Africa, and it ranges between 67%, actually the highest in Zimbabwe, to 29% in Mozambique. And when we really look into the timing of starting ART, this is a paper that was published in 2012 from South Africa, which looked into the timing of initiating ART in 274 eligible people living with HIV, where only 58% were started within the first 8 weeks, according to the WHO recommendation. And even to start, it took 51 days, which ranged between 29 to 77. And when it's only 13% of those with CD4 count less than 50 were started on within the first week. So this actually explains why there is a still higher undiagnosed TB and TB-related mortality. So this slide shows again the disparity between the services for ART and TB in selected countries. Actually, these are the four biggest countries with the highest burden of HIV-associated TB in Africa. And as you can see, there are more TB providing facilities in red compared to ART facilities in blue. And in some countries where there was actually very low coverage of ART, like Mozambique, where we saw 29% coverage of ART, you can really see big disparity between the TB facilities and the ART facilities. And of course, in order to address this, the services have to be integrated. And when we say integrated services, we need more physical space. We need really renovating or restructuring our facilities. It needs training for qualified staff and robust monitoring and evaluation. And most importantly, also addressing infection control, especially if we are bringing people living with HIV with potentially infectious TB cases. That has to be very well addressed. And one other important is really the baseline ART evaluation, which we are increasingly identified as a barrier for earlier access of ART for TB patients. And in some countries, like in India, where they have actually a very good system of providing integrated TB and HIV services, the baseline ART evaluation can take between 4 to 6 weeks. And someone with TB diagnosed for ART, the baseline, the literacy, the baseline testing, and clinical evaluation can take that long. So I think this has to be stopped as soon as possible, while the patients should get ART with their TB treatment, and the all evaluation and the patient literacy can continue concomitantly. So this should be also part of the integrated TB and HIV service provision. Another important thing that we should do really to maximize synergies and use existing opportunities. We heard this morning a very exciting and interesting campaign, community-based campaign on HIV testing from Swaziland, but I was basically appalled not to hear even a single time the word TB. We know in Swaziland, almost half of the people living with HIV are getting TB, and 80% of TB patients are HIV positive. And in this situation, actually what we are discussing globally is whether we should really go for a TB as well as HIV program, or should we go really for one HIV and TB program. You know, this is the things which we are discussing. And I was in Maputo 2 weeks ago, and we had interesting meeting with program managers from HIV and TB from 14 African countries, Swaziland included. And a lot of countries are really scaling up the provision of integrated services. However, when the services are scaled up, the challenges they are facing is stock out of IPT, INH, stock out of HIV testing, stock out of materials and supplies. And these are not issues that are addressed by just having service provision, integrated service provision. It really needs integration at a higher level. And the call from those program managers is actually, it is time now we should consider integrating our program management, our planning, and the like. And this was not the case even 3 years ago, when we at WHO discussed with member states how we can handle this, and there was a lot of turf protection. But now I think that has evolved in a much more positive way, that we have to really use this as an opportunity. And related to this is also the need for multidisciplinary research. We don't know really what this integration will lead to, what is the impact, and there are quite a lot of questions, especially if we really use TasP and TB in this context, that we should know, and we should really know the process and the impact at all community service and management level. We should know the enablers for successful integration, and we should really have socio-political interventions, just like what we heard, the qualitative research this morning from Kenya. Really discordant couple, which you really think could be happily, accept TasP. There are quite a lot of issues that have to be really looked into a much more multidisciplinary socio-political aspect. This is a graph I took from the paper published by Granich and his colleagues in 2011 that actually showed the list of countries planning or implementing TasP research. And again, it was very surprising, of all those 22 planned or ongoing TasP research in Africa, only 7 actually put TB either in their interventions or in their outcome. And 1 out of 4 was also included in Asia. So this is why we have to really think, when the program managers are thinking really to integrate, basically really to mainstream, I think that has also to be filtered into the research community. And some people actually say we are probably thinking wishful marriage. And you can surmise which one, who is TB and who is HIV here. And I actually borrowed the slide from an HIV expert presentation. And when you really look, actually, this is a true story from the BBC, where a man aged 24 actually weds a 82-year-old bride. And don't ask me how long they stayed, but at least it is possible. So in a serious note, on conclusion, we have to really promote earlier and joint diagnosis and treatment of TB and HIV at community and facility levels, and ensuring 100% coverage of ART for TB patients can be a proxy to overcome challenges for TasP. If we don't succeed on 100% ART coverage for TB patients, that will cast a question on our efforts on TasP, and rapid adoption and rollout of national policies is crucial for scaling up, and how can the research community can help. And as I said, the TasP research, particularly in Africa and Asia, should embrace TB and address unmet research needs. Thank you very much.
Thank you for that great talk. And